lives. It is characterized by neck stiffness, discomfort, and the restricted range of motion. Prolonged neck postures, palpation of the cervical muscles, and neck movements basically aggravates the non-mechanical neck pain. Scapula and axioscapular muscles have a crucial role in the neck movement. Therefore, altered axioscapular muscle function can cause neck pain. Upper spine and the thoracic spine are biomechanically and ergonomically related to each other. Therefore, hypomobility in the thoracic region could be the reason of functional limitations and reduced range of motion in patients with mechanical neck pain. Therefore, both scapular stabilization and thoracic spine extension exercises incorporate the 3D of regional. A study by Hengen et al. On the effects of the thoracic spine mobility exercises on chronic neck pain and disability in the young adults stated that thoracic exercises would be a great exercise treatment for the patients with neck pain in reducing their neck pain and reduction in their disability. Moreover, a study on the effects of combination of the scapular stabilization and thoracic extension exercises for the office workers with forward head posture on the craniovertebral angle, respiration, pain, and disability stated that combination of both exercises which are not directly applied to the neck, incorporating the theory of regional interdependence, showed improvement in the posture and significant reduction in pain, range of motion, and disability. A randomized clinical trial was conducted in the Fatima Memorial Hospital and the Boston Physiotherapy Wellness Clinic of the Lahore, and a non-probability convenience sampling was done for the recruitment. Sample size was 30 and it was divided into two groups, the scapular stabilization group named as Group A and the thoracic extension exercise group named as B. Inclusion criteria includes males and the females with the age of 18 to 40 years, with NPRS score less than 7, NDI less than 25, and having the mechanical neck pain for more than 3 months. Also included the patients with neck pain whose pain provoked by the neck movements and palpation of the musculature of the cervical region. Cervical radiopathy, traumatic neck injury, osteoporotic vertebral fracture, tumor, pregnancy, history of the cervical and thoracic spine surgery, neck pain associated with vertigo were the excluding factors. Numeric pain rating scale was done to assess the pain, NDR was done to assess the disability, and goniometer was done to measure the range of motion. Intervention, the Group A with the scapular stabilization exercise basically comprised of the 4 exercise programs. The first one was the scapular retraction exercise. Second exercise was the scapular mobilization exercise in which the patient raised their arms sideways in line with the shoulder, keeping the thumbs up. Third one was the scapular dynamic stabilization exercise in which the one hand was beside the ear and one was beside the back, and similarly on the contralateral side. Scapular dynamic stabilization exercise 2 basically comprised of lifting the arms sideways in line, keeping the thumbs up, and then pushing them down in the 90 degrees of the position. It was done with the 3 sessions per week at a frequency of 2 sets of 10 repetitions for a total of 6 weeks. Second, the Group B was treated with the thoracic extension exercise, which basically comprised of the 3 exercises. On the first exercise, a foam roller was placed in between the T2 to T4 to treat the hypomobility. In step 2, a Swiss ball was incorporated and hands were placed and the Swiss ball was moved to a distance with the arm. Third exercise incorporate the prone lying position with elbows up and the body in the thoracic extension. Similarly, they have the 3 sessions per week at a frequency of 2 sets of 10 repetitions for a total of 6 weeks. Moreover, the common treatment involves the hot pack and tense in the prone lying position for the 10 minutes, cervical isometrics in the flexion, extension, side flexion, and the rotation were done in the sitting position at a frequency of 1 set of 10 repetitions for a total of 6 weeks. 40 participants were eligible for the study, 6 were excluded, and 3 did not meet the inclusion criteria, and 3 rejected to participate in the study. So 34 participants were randomized through the simple randomization through a sealed opaque envelope method, and they were allocated into 2 groups, with each group containing 15 participants. After the treatment and the follow-up, only 15 participants in each group was present, and 2 from each group discontinued. Analysis was done on the 15 patients, and the results are 70% of the males were incorporated in my study, and 70% females were incorporated in my study, and there were 30% males. Between group comparison of the pain through the NPRS scale clearly indicates that there is the difference in the pain and there is reduction in the pain in both groups with p-value greater than 0.05, which states that the results were statistically non-significant. Between group comparison of the disability states that there is reduction in the disability of both groups with p-value greater than 0.05, which indicates that the results were statistically non-significant. Between group comparisons of the range of motion of the cervical flexion also states that there was improved in the range of motion in both groups, and the p-value was greater than 0.05, which states the results were statistically non-significant. Between group comparison of the cervical extension states that there was an improved range of motion in the extension of both groups, but p-value was greater than 0.05, which shows the results were statistically non-significant. Within group comparison of the NPRS through the paired sample t-test indicates that the mean difference in the group A was 4.87, and in group B it was 5, which is more or less similar, with p-value less than 0.05, indicating that results were statistically significant. Moreover, the within group comparison of the disability states the mean difference was 19.21 and group B was 21, and the results were statistically significant. Within group comparison of the range of motion of cervical flexion showed the mean difference between the 2 groups were 17.3, 16.53, and the results were statistically significant. Lastly, the range of motion of the cervical extension within group comparison indicates the group A has a mean difference of 15.06 and group B was 12.8, indicating that the results were statistically significant. Discussing this and comparing this with the previous article by Swan et al. To study the effects of scapular exercises in participants with neck pain, which concluded the scapular exercises could reduce the disability and pain in the neck, but there was no remarkable difference in the group. These results were aligned with the current study, which stated that pain and disability reduces. The pain and disability was reduced after the incorporation of the scapular stabilization and thoracic extension exercise. In 2021, a study on the combined effects of the scapular stabilization and thoracic extension exercise resulted that both exercises are combined, there would be the better outcomes. So the results of the current study showed that both the scapular stabilization and thoracic extension exercises are equally effective in reducing the pain and disability in patients with neck pain. Therefore, my study concluded that the treatment regimes, scapular stabilization exercise and the thoracic extension exercise were equally effective in reducing the pain, disability, and improving the range of motion in patients with mechanical neck pain. Lack of cooperation of the patients for follow-up and the nature of the job of the participants were not taken into the consideration, and that were the limitations of my study. So I recommend the clinically inference is to incorporate both regimes to achieve more advantageous results in patients with mechanical neck pain. And in future studies, it is very important to identify the long-term effects of these interventions, integrating the large sample with numerous population. And these are the references. Thank you so much.
Thank you, Anam Abbas. It was nice hearing you. Our next presenter is Rahat Afzal, I invite her to please come on the stage and start her presentation.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. It is an honor for me to today present my article entitled as Effects of Mulligan Mobilization with and without clamshell exercises on pain, disability and quality of life in patients with the sacroiliac joint dysfunction. SA joint dysfunction is one of the most leading cause of the low back pain, and the prevalence of SAJ is 15 to 30% among the population. The symptoms of SAJ dysfunction is very dull and the aching pain without burning, numbness and the tingling sensation that sometimes radiate up to the ipsilateral groin and the buttocks region. The diagnosis of the SA joint is little challenging. A complete history and criteria is used for the non-provocation test, and there is a list of the 6 non-provocation tests called the Leslet's criteria. In this criteria, the 6 tests includes compression test, distraction test, thigh thrust test, Genslin's test, and the Patrick test. Out of these 6 tests, if 3 tests considered positive, we will term as that sacroiliac joint dysfunction is present in this patient. Sacroiliac joint dysfunction is a broad term in which there was different dysfunctions occur. Interior innominate dysfunction is one of the most common positional fault that occur in the SA joint dysfunction. One of the most important therapeutical exercises that are very effective for the treatment of SA joint dysfunction is the clamshell exercises, which basically focus on the strengthening of the gluteus medius muscle, that is the basic hip stabilizer muscles, and in SA joint dysfunction, hip abductors are basically going into the weakness. And one of the most effective treatment for SA joint dysfunction is the Mulligan mobilization with the movement that improve the pain and improve the dysfunction and has a long-lasting effect on the patients. Previously, a study conducted in 2021 which compares the Mulligan mobilization versus the spinal manipulation effects on the low back pain, and the finding indicates that the spinal stabilization exercises with spinal manipulation had better effects rather than the Mulligan. So they basically say that the spinal stabilization exercises are more effective rather than Mulligan. Another study conducted in the 2019 that compares the effect of muscle energy techniques in the chronic sacroiliac joint dysfunctions, and the result revealed that muscle energy techniques are more effective in the patients with the sacroiliac joint dysfunction as compared to the traditional treatment that includes the therapeutic exercises or different modalities. This type of a study design is a randomized clinical trial, and the data is collected from the physiotherapy department from Fatima Memorial Hospital and the Boston Therapy and the Wellness Clinic. The duration is 6 months after the approval of synopsis, and non-probability consecutive sampling technique is used. The total sample size is 38, 19 in each group, and group A is treated with MWM and the standard treatment, and group B is treated with MWM along with clamshell exercise. In the inclusion criteria, the participants between 20 to 25 years of age included, with both males and females, the sacroiliac pain of subacute level with at least duration of 4 weeks, patients with positive Leslet's criteria, NPRS score less than 8, and ODI score between 20 to 40%. All the participants were excluded with any kind of a deformity like spondylosis, lumbar canal stenosis, congenital deformity, lumbar disc herniation, or any kind of a postures. So these patients are excluded. 3 types of data collection tools are used. For pain, numeric pain rating scale is used. For disability, oswestry disability scale is used. And to check the quality of life, EQ5T scale is used. The intervention of, we have the common intervention or a standard treatment that is given to the both groups includes the ultrasound therapy with 1 megahertz on 3 minutes duration for each patient, and hip abduction and the adduction isometric hold exercises and stretching of the quadratus lumborum muscles. In group A, along with this common treatment, the MWM is performed with the frequency of 3 sets with 10 repetitions 3 times per week with a 3 minutes rest between each exercise for the 6 weeks. And the same treatment is given to the group B, but addition of the clamshell exercises. The consort flow chart indicates that a total 46 participants were eligible for including in my studies, but 4 were excluded due to some reason, and 42 were randomly allocated into the 2 groups, 21 in each group. And 2 participants were dropped out due to some reasons, and an analysis was done on the 38 patients, 19 in each group. The gender distribution includes that there is almost 60% females and 30% male, including in these studies. And the within group comparison of NPRS indicates that there is a mean difference between 2.47 in group A and 4.68 in the group B, and the p-values are less than 0.01, which indicates the results are significant. Within group comparison of ODI also indicates the p-value is less than 0.001, which indicates there is a difference in ODI. The comparison of EQ 5-day also indicates the p-value is less than 0.001, which indicates the results are significant. Now we're moving towards the between group comparison of the NPRS scores. As you see the graph, the bar charts, the blue indicates the pre-values and the green indicates the post results. So you can clearly see that in the both groups, the pain level is decreased. But you can see the second group in which we will perform the MWM with clamshell has more reduction in the pain as compared to the group A. Next, there was a comparison of ODI, and again in the bar graphs you will see that there is decrease in the disability level in both groups, but more effect occur in the second group in which MWM with the clamshell is performed. And last, there is a quality of life. You will see the green line indicates the quality of life is improving both the patients, but again, group B has more effect. Like the conclusion is that both treatments are equally effective, but MWM and clamshell show more significant results. A previous study occurred in 2022 compared the effect of the MWM versus the manipulation with taping in the interior innominate dysfunction, and the results said that MWM is effective in decreasing pain level, but there was no significant difference in the decreasing the disability of the patient. And my study is also concluded that MWM is effective in decreasing pain and disability and improve the range of motion with the remarkable results. Another study also conducted in 2022 in which they see the comparative effect of the conventional therapy with and MWM on pain and the function disability, and they said both treatment has equal effective in decreasing pain and improving the quality. And in my current study, which also favors the same study results, that MWM either with or without clamshell exercises is more or less equally effective to relieve pain and the disability in the patients. The conclusion said that both treatment techniques was effective in produce significant differences in NPRS, ODI, and EQ 5D, but MWM with clamshell exercises had shown more significant results. The limitations are lack of cooperation of patients for the follow-up and the nature of job of the patients, like what occupation belongs to the patient. That is not included in my study, so that is a kind of a limitation. I give recommendations on 3 departments. For clinicians, I would say that clamshell exercises should be added into the treatment plan whenever you treated the...
Rahat, carry on.
You treated the patients with interior innominate dysfunction, and for researchers you should be working on the modified clamshell exercises with the different angles are also incorporated, so you also study for that, and awareness of the students among the importance of the clamshell exercises, because that are the particular exercises that work on the strengthening of the gluteus muscles group, and these are the references. Thank you so much.
Rahat, excuse me, can you please repeat the Mulligan mobilization methodology? Can you repeat please? The Mulligan mobilization.
Sorry, sir, I don't hear you.
Mulligan mobilization.
जी सर.
The methodology you use in Mulligan mobilization, which type of mobilization?
Okay, sir, the patients I including in my study is the interior anomaly dysfunction.
Do you have any picture?
No, I don't have any picture.
Okay.
I don't including any picture, but the position of the patient is in the standing, and I just hold it up, and then it will go into the extension, and along that I just maintain the mobilization and I perform that mobilizations.
You mean snags?
Yes, sir.
Okay.
Thank you, sir. Thank you, sir.
Thank you, Dr. Rahat Afzal, for your presentation. Our third presenter is Dr. Ahmed Jamal, who is going to talk on the effects of suboccipital muscle inhibition technique on pain, functional disability, and quality of life in patients with SIJ pain. Please come on the stage and start your presentation.
Assalamu alaikum. Today's my topic is about the effects of the suboccipital muscle inhibition technique on pain, functional disability, and quality of life in the patients with sacroiliac joint pain. So first of all, we are going to talk about the sacroiliac joint. It's made up of the sacrum and the two iliacs. On the each side there is a left on the right, and it is used for as a weight transmission from the lumbar spine to the lower extremities. Most idiopathic lower back pain discomforts with the patients, at least 15 to 30% of the patients also presented with the sacroiliac joint pain. Okay, sacroiliac joint pain. The Leslie's criteria was introduced for the pain provocation test for the SIJ, in which 5 tests were included. One was the compression test, one was the distraction test, the third one was the thigh thrust test, and the fourth one was the Galsland's test, and the fifth one was the Patrick's test, also known as the figure 4 test. In it there was a SMIT, the suboccipital muscle inhibition technique. To perform it, you have to sit on the head, on the side of the head of the patient, and you have to bend your fingers on the 90-degree in the space of the suboccipital space, in which the C2 and the subocciput space, and you have. Okay, sir. Okay, in the previous study, the suboccipital muscle inhibition technique versus the craniocervical flexion exercises for increasing the hamstrings flexibility, Sakshi performed this study in 2021, in which both results were the same, both were the effective studies, in which SMIT and CCFE both were the effective. In the second one, Vidya presented this study in the comparison of gluteus maximus activation with the flexion bias exercises along with the METs, in which the flexion bias exercises along with METs and SMIT were more effective than the other one with the control group. This was a randomized control trial, and the study settings were the Noor International University Rehabilitation Clinic, PSRD Fatima Memorial Clinic, and the patient sample size was 38, each group with 19. One was the control group, one was the experimental group. In the control group, only conventional treatment was given, whereas in the group B, which is the experimental group, conventional treatment with suboccipital inhibition technique was given. Inclusion criteria was the age limited was 18 to 25, both genders were included. According to the Leslie's criteria, after that NPRS and the point of 3 and ODI score was moderate disability, which is 20 to 40%. Exclusion criteria includes different pathologies and deformities of the spine, like osteoporosis, disc herniation, fractures, spondylolisthesis, and any systematic diseases. Infection, inflammatory diseases, and pregnancy and pelvic bone fractures were also in the exclusion criteria. Three tools were used for pain. NPRS was used for disability, ODI, Urdu variant was used, and for the quality of life, EQ5D5L was used. As I already explained that in the invention, that the control group only received the conventional treatment, whereas in the experimental group, the patients received SMIT with the conventional group. In the conventional group, some modalities, electrotherapy and METs were involved, in which hot pack for the 10 minutes, TENS transcutaneous electric nerve stimulator with the burst mode 3 Hz frequency and 10 minutes duration, whereas the therapeutic ultrasound in the pulse mode, 0.08 intensity with the duration of the 6 minutes, and METs for the SIJ with 2 sets, 5 repetition, 10-second holds in autogenic muscle elimination. In the result of the demographic, all p-values were more than 0.05, which was saying that the groups were inhomogeneous. Whereas in the between group difference, the ODI decreased from 30 in the experimental group from 30 to 13 and the 12. First one was the baseline. The second one was the post-treatment after 2 weeks, 7 sessions was given, alternative days. And the third one was the follow-up, which was given after the 4 weeks. Again, for the NPRS, same 3 values was taken at the baseline from the pre-treatment and then post-treatment and then from the follow-up. And third one was the EQ5D5L, in which the patient's quality of life increased with the passage of time, and the post-treatment were the most effective one. In the previous study in 2018, BUSMA conducted this study on the effects of the SMIT on the lower back pain, on the function intensity and the functional disability. It was effective in both of that, as my study said that the effectiveness of the SMIT on lower back pain with SIJ is also effective. Conclusion is that indicating that the inclusion of suboccipital inhibition technique in conventional treatment may provide enhanced therapeutic effects and benefits to the patients. Limitation, lack of cooperation with the patients on the third follow-up. Basically on the pre and the post one, the good one, and the follow-up there was a lack of cooperation. The third one was there was a long-term treatment in the short period of time. The third one was there was not a vast variability within the age, gender, and ethnicity. In the recommendation, you can also conduct SMIT's effects on the thoracic region, and you have to be aware of the clinician has to be aware of the suboccipital inhibition technique. In the further investigation, the mechanism on the mechanism was not really defined. In the previous study, it was defined as a theory one, that the SMIT can affect the lower back hamstrings by relaxing the muscles, by ligaments, which were the supraspinous ligament or interspinous ligament, or third one was the fascia. So we need further studies on the mechanism, how SMIT is relating to the lower back and lower extremities. So these are the references. Thank you.
The next presenter is Dr. Tahreem Raza, who will talk on the effects of concentric exercises with and without mulligan wrist mobilization on pain, grip strength, range of motion, and function after. Please come and start your presentation.
Bismillahirrahmanirrahim. Assalamu alaikum. I am Tahreem Raza and I am here to present a study related to effects of concentric exercises with and without mulligan wrist mobilization on pain, grip strength, range of motions and function after distal radial fracture. DRF accounts for 12% of elderly fracture. Common cause is usually falls on outstretched hand. Mobilization with movement is sustained, is usually active mobilization of the joint, where sustained passive accessory glide is maintained with simultaneously active movement of the joint occurs. It causes mechanical, physiological and psychological effects. It decreases the pain by stimulation of endogenous pain modulation. It also causes repositioning of the joint. When the pain decreases and the functions improve, it decreases the negative psychological manifestation which is usually associated with the fracture or any type of the injury. In 2021, a systemic review was conducted to check the manual therapy effects on DRF patients. The study gives low to high evidence in the favor of mulligan mobilization with movement after DRF. Similarly, in 2021, a systemic review was conducted to check the effects of supervised exercise therapy after non-surgically treated DRF. Early mobilization was not proved to be effective as compared to the other treatment, while the studies which were included in the systemic review was low-quality studies. This study was conducted in DSU Hospital, Sheikhpura. Sample size was 22. In group A, mulligan mobilization with movement and concentric exercises was applied, and group B, concentric exercises alone was applied at shoulder, wrist and elbow joint. NPRS, goniometer, hand dynamometer and patient-rated wrist evaluation score was used. 45 to 65 age patient were used, and the patient with at least 6 weeks of distal radial fracture was included. And patient with any neurological problem, polyarthritis, bleeding or any other fracture were excluded from the study. Wilcoxon test, Mann-Whitney test, independent sample t-test, impaired sample t-test was used in the analysis. Before treatment, in demographic data, there was no significant difference between the groups. After applying the treatment, all the outcome variables were improved in both groups. However, in between the group comparison, mulligan mobilization with movement group shows better outcome as compared to the other. However, in ulnar deviation, no significant difference was occurred between the groups. Our current study is in favor with the previous study, which was also give results in the favor of mulligan mobilization with movement after DRF. However, the previous studies only included non-operated patients which were treated non-operatively after DRF. However, current study included both patients operatively and non-operatively treated. Similarly, in the previous study, flexion, extension, supination and pronation was assessed, while the current study also assessed ulnar deviation and radial deviation. and shows ulnar deviation showed no significant difference between the groups. Similarly, in previous study where 9 RCTs were reviewed, all of the ranges were improved after Mulligan mobilization with movement. However, current studies proves no significant change in ulnar deviation between both groups. However, it is concluded from the study that Mulligan mobilization with movement is important for the rehabilitation and should be included in the early mobilization after the DRF fracture. And it is recommended to include in the early rehabilitation process. These are the references. Thank you.
Thank you, Dr. Tahreem Raza. Our next presenter is Dr. Sana Gohar, who will talk on the effects of core muscle activation exercise training on pain, range of motion, and function in patients with chronic low back pain. Please come and start your presentation.
ठीक है आप कर लें Assalamu alaikum. The topic of my presentation is effects of core muscle activation exercise training program on pain, range of motion, disability in patients with chronic low back pain. So, as we all know that the chronic low back pain is the most prevalent disability worldwide and experienced of all age groups. So what happens when we adapt the poor posture for the long time, like our neck muscles, our back muscles also got weak and stiff. So mainly the multifidus and the transverse abdominis muscle got weak and stiff. So the basic purpose of my research was to investigate the effects of core muscle activation exercises on pain, range of motion and disability. Now, if we define the core, it's the muscular box in front of your body and provides the stability to the spine. Let's jump to the literature review and literature gap. I'm quickly summarizing it. Previous researches was mainly targeted the pain variable only. Also, they were focused on the acute low back pain and they didn't combine the manual therapy technique with core stabilization. Yet they concluded the core stabilization exercises were beneficial, but on different variables and different perspectives. So our study was mainly focused on spinal mobility, functional disability, and mobility as well. This was the literature gap that I already defined. Material and methods. Our study design was randomized clinical trial, and our sample size was 34. We selected both, okay, next. We selected both the genders with the age range 20 to 50 years, and we excluded all the patients with systemic illnesses. These were the tools that we used in our research. So let's come to the interventions. We had two groups. In group A, we first taught the patient about the ADIM technique. So what is the ADM-IR technique? It's a technique that activates the transverse abdominis and deep abdominal muscles, and this mainly focuses on the deep core muscles. So first we ask them to do this technique, and after this technique we ask the patient to do all these exercises that I have shown in this PowerPoint. In group B, we gave the Maitland mobilization in grade 1 and grade 2. So we had almost in anterior or posterior direction. For the per session we had about 45 to 60 minutes, and we had 3 sessions per week, and we follow up for the 3 weeks. We had the common intervention of Maitland mobilization in both groups, plus we had TENS and ultrasound. So let's come towards the results. Now, as you can see that the graph summarizing our results, mean values are on the y-axis and the study groups on the x-axis. The blue line indicates the pre-treatment value of pain in both the groups. The green line indicates the second reading value, and the yellow line indicates the third week results. And as you can see, the line drops more towards the core muscle activation exercise group, which means pain decreases more significantly in core muscle activation exercise group, and same for the disability index. If we talk about the range of motion, as you can see now the lines are in the improving side, because the range of motion was improving day by day, but more significantly in the core muscle activation program. Same for the lumbar right side bending, lumbar right side bending and left side bending, for lumbar right rotation and lumbar left rotation. So let me quickly describe the discussion. Previous researches, like in 2019, they concluded only the short-term effects of the functional disability and pain, while in our study focuses long-term effects. Another study was done by Gulsa in 2019, and this was the semi-agreement with our research, because the value of pain and disability was not significant, but yet they also proved that the core muscle activation exercises were beneficial. The possible reason for the confliction might be the exercise frequency, assessment method, and the stage of low back pain. So I just summarize all it. Conclusion. So our study concluded that the core muscle exercise program was more effective in treatment of the patient with chronic low back pain, with significant improvement in all measuring outcomes, including pain, disability, and spinal mobility. So among the basic limitation that we faced was the blinding of the patients, plus the understanding of the proper ADIM technique, which was difficult for us. Due to the budget issue, we can't measure the isolate muscle activity through diagnostic ultrasound and EMG studies. Recommendation. For the future recommendation, we would recommend the future researchers to use the myometer to assess the change in muscle tissue quality before and after, particularly in each muscle. And awareness of the clinician and wise practitioners for the proper usage of ADIM technique, because when we use the core muscle activation exercises, like the bridging exercise, we miss this ADIM, because what is ADIM? It is just a tummy tuck in, and we just miss it, and it is the major part that we miss, and it is very important in the activation of core muscle activities. These are the references. Thank you.
Thank you so much, Dr. Sana Gohar. Our next presenter is Dr. Ifra Zulkarnain. She will talk on the effects of Rockabido's approach versus cross-exercise therapy on pain and disability in patients with temporomandibular dysfunction. Please come and start your presentation.
Assalamu alaikum. Good morning, ladies and gentlemen. First of all, I would like to thank Rifa International University who provide opportunity to me for presenting my research topic here. It's me, Dr. Ifra Zulkarnain, Awan, gold medalist from Rashid Latif Medical College, affiliated with University of Health Sciences. Today I am going to present my research topic, which is effects of Rockabido's approach versus cross-exercise therapy on pain and disability in patients with temporomandibular dysfunction. Hello. Effects of Rockabido's approach versus cross-exercise therapy on pain and disability in patients with temporomandibular dysfunction. Temporomandibular joint is one of the body's most intricate part which connects the jaw to the temporal bone of the skull. It is divided into two types, acute TMDs and chronic TMDs. Chronic TMDs significantly affects the women, while acute TMDs are equally common in both genders, males and females. The prevalence of TMD rises between the ages 45 to 64, whereas frequency was highest in women who are at childbearing age 20 to 40 years. Temporomandibular joint basically affect the temporomandibular structure. It includes muscles of mastication, ligaments, fascia, and all the musculoskeletal tissues in the head and neck region. And interdisciplinary strategy incorporating conservative and surgical treatments can be used to treat temporomandibular disorders. Based upon the treatment, it includes education, self-care exercises, medications, physiotherapy, occlusive splint therapy, behavioral and psychotherapy are examples of conservative treatment. Now let's move towards the literature review. Based upon the previous literature, a study conducted in 2019 on the effectiveness of Rockabido's approach and conventional physiotherapy on pain, ROM, and quality of life in patients with TMJ dysfunction. And this study concluded that Rockabido's approach along with TENS was potentially successful strategy in the treatment of TMJ dysfunction. Another study in 2020 conducted which was prescriptive exercise for TMJ disorders. This study concluded that physical therapists typically use assisted stretching and resisted strengthening exercises as a part of their exercise regime. Another study in 2012 conducted on automobilization interventions and exercises for TMJ open lock. This study concluded that 6x6 Rockabido's approach has been used for mandibular neuromuscular control during activities involving extreme mouth opening. Another study in 2013 conducted on therapeutic exercises for the control of temporomandibular disorders. This study concluded stretching, strengthening, and coordination exercises were useful in the treatment of muscular TMJ disorders. My literature gap was that there was limited literature on the effectiveness of Rockabido's and cross exercises independently. In our research, we did the comparative effects of Rockabido's approach and cross exercises on pain and disability in patients diagnosed with temporomandibular dysfunction. Our material and methods include study design. The study design was randomized clinical trial. This was a registered trial under clinicalgovernment.org. The study settings was Fatma Memorial Hospital Physical Therapy Clinic and Boston Physiotherapy and Wellness Clinic. The duration of this study was 6 months after the approval of synopsis, and non-probability consecutive sampling technique was used. The groups was divided into two forms. Group 1 received Rockabido's approach and Group 2 who received cross exercises. Based upon the sample size, the total sample size open epi tool was divided into 40, allocated into two groups, 20 each. Inclusion criteria was age between 20 to 60 years, FAI severity score mild and moderate, patients with TMJ clicking sounds, patient with jaw pain and limited jaw range of motion and limited mouth opening and associated pain. Pain upon muscle and joint palpation, basically masseter muscle. Our exclusion criteria was FAI score severe category, neurological problems, illiteracy, dementia or blindness and pregnancy. The outcome measurement tools was numeric pain rating scale for pain, TMJ disability index questionnaire for disability, and Fonseca anamnestic index for severity. Now, let's move towards intervention. Group 1 received Rocabdo's approach. It consists 6 repetitions, 6 times a day, thrice per week for 4 weeks. It comprised of 6 exercises. Number 1, tongue at rest position, control of TMJ rotation, rhythmic stabilization technique, neck axial extension, posture of shoulder joint, head flexion stabilization. First exercise, tongue at rest position, was performed. This was the diagram of Rocabdo's approach. You can see there were 6 exercises based upon 6x6 protocol of Rocabdo's approach. In first one, the tongue was placed at the roof of your mouth just behind your front teeth. In number 2 diagram, tongue was placed at the roof of your mouth and jaw-mouth opening was performed. In number 3, tongue was placed at roof of your mouth and resistance was given under the chin. In number 4, neck axial extension was performed, and in last one, scapular squeezing exercises was performed. Now let's move toward group 2. It was cross exercise group. It was given on the frequency of 2 sets and 10 repetitions twice a day, 3 times per week for 4 weeks. It concluded that 8 exercise regime was given to the patient, which include resting position of the tongue, teeth, distant nasal diaphragmatic breathing, tongue upward and wiggle, strengthening, touch and bite, neuromuscular control, and isometric exercises. These exercises are included in cross exercise group. Now let's move towards data analysis. Data was analyzed by IBM SPSS statistical package for social sciences. Significance value was set at 0.05. Descriptive statistics shows frequency table, pie chart, bar chart. Inferential statistics show difference across group and difference within the group. Within group, difference was found by Wilcoxon signed rank test, and difference across groups was measured by Mann-Whitney test because our data was non-normally distributed. These are the demographics, histogram of age, and pie charts of gender. Now, within group comparison of NPRS showed that there was statistically significant difference in group 1 and also in group 2 based upon the p-value. Within group comparison of TMD also showed that there was statistically significant difference between group 1 and group 2 because their p-values was less than 0.05. Within group comparison of Fonseca questionnaire also showed that group 1 and group 2 both are effective because their p-value was less than 0.05. Now, between group comparison of NPRS showed that there was no statistically significant difference between these two groups, and these two groups found equally effective in the treatment of TMJ disorders. Between group comparison of TMD also showed that there was no statistically significant difference between treatment of these two groups because their p-value is more than 0.05. Between group comparison of Fonseca questionnaires also showed that there was no statistically significant difference between both techniques, and it was concluded that both techniques was equally effective for the treatment of TMJ dysfunction. According to discussion, previous study showed that ischemic compression technique on pain and functionality in TMJ disorders, and it was concluded in the previous literature that exercise alone and exercise combined with ICT have equal effects on ROM, discomfort, and functionality in patient with TMJ disorder. In our study, both groups show a significant difference in TMJ disorders. Another study conducted on the effects of ultrasound TMJ manipulation and exercise on pain and mouth opening in patients with TMJ dysfunction, and it was concluded that ultrasound manipulation and exercise targeting the TMJ are effective for TMJ dysfunction, and in our study both groups experienced improvement in pain and disability as well as reduction in the severity level of TMJ dysfunction. The limitations of this study was participants' choice of food they preferred before and after treatment was not taken into consideration. That might have an impact on pain, disability, and quality of life. Some participants used night guard to prevent teeth grinding and to avoid psychological distress recommended by dentists. Our future recommendations are awareness to students about the importance of Rehabilitation's approach and cross exercises, and both Rehabilitation's approach and cross exercises are advised by the clinician for wider application on patients seeking rehabilitation for TMJ pathologies. These are the references of this study. That's all. Thank you.
Thank you, Dr. Ifra. Our next presenter is Itamadur Rahman, who will present his work on the topic of comparative effects of calisthenic and resistance exercise on pain, function, balance, and quality of life in knee patients. Please come and present your work.
Assalamu alaikum and good morning, ladies and gentlemen. I am Dr. Itamadur Rahman, working as a clinical physiotherapist at Rising Sun Institute for Special Children. I am honored to stand in front of you to discuss the topic of paramount importance in the field of rehabilitation sciences. I would thank conference committee for giving me this opportunity. My topic is comparative effects of calisthenic and resistance exercises on pain, function, balance, and quality of life in knee osteoarthritis. As you all know, osteoarthritis is a degenerative and progressive disease of joint articular capsule, and it may also include subchondral structures like ligaments, peripheral nerves, periarticular muscles, and synovia. It is the most prevalent and commonest disease of the joints between the ages of 40 and 70 and affects more than 250 million people worldwide. Female gender, metabolic diseases, weight, layer lifestyle, and trauma were all connected to significantly higher incidence of knee osteoarthritis. Calisthenic exercises are the ones in which body weight is used to increase strength, flexibility, and functionality. These exercises are also used in rehabilitation and sports as they lead toward the improvement of strength and flexibility. Resistance exercises are the main exercise program that used to increase muscle strength and muscle mass. A variety of studies exist in which therapeutic exercises are recommended as non-pharmacological interventions for knee osteoarthritis treatment. Literature view is that in 2022, a study shows low-intensity resistance exercises were more tolerable, making them more appropriate for the treatment of knee osteoarthritis. Calisthenic exercises, along with the conventional treatment exercises, are more beneficial for pain reduction and improvement in function, resulting in speedy and early recovery for knee osteoarthritis. Significant improvement in pain among patients of knee osteoarthritis have shown using calisthenic type of exercises in a study conducted 2020. Improvement in pain and physical function in patients with knee osteoarthritis, and most common method used was to strengthen the quadricep muscle, which affects positively pain and function. It was concluded in a study conducted in 2019 that squatting, which is a type of calisthenic exercise, helped in the reduction of inflammation, pain, and improvement in function, knee stability, range of motion, and muscle strength. The rationale for my study was pain management along with the improvement of quality of life, function, balance. Pain management was a primary concern because the reduction in pain ultimately leads to the improvement of all other function. Strengthening of muscles surrounding the knee was also targeted by using the two exercises to provide the best exercise plan to deal with this condition. This is the null and alternate hypothesis for my study. The study design was randomized clinical trial. All data was collected from the physiotherapy department of Muhyiddin Hospital, Mirpur. Study duration was 10 months and the total sample size was 26 divided into 2 groups of 13 each. Sampling technique was non-probability convenience sampling, and the study group A was given calisthenic exercises and group B was given resistance exercises. The inclusion criteria for my study were both male and female gender between the ages of 45 to 65 and with diagnosed grade 2 or grade 3 knee osteoarthritis with symptoms for at least 3 months. Exclusion criteria was any inflammatory joint disease like rheumatoid, gouty, psoriatic arthritis, any neurological defects like sensory loss, radiculopathy, paresthesia, myelopathy, any peripheral vascular disease, surgery related to the lower extremity, or any metal implant. The data collection tools were Berg Balance Scale for balance, numeric pain rating scale for pain, short form quality of life questionnaire for quality of life, and WOMAC scale for function. Procedure was started with the consent, and then the patients were randomly allocated into 2 groups. The baseline treatment for my study was hot pack given to both groups for 10 minutes. Group A, those receive calisthenic exercises like abductor leg raise, calf raise, and lunges. With baseline, Group A received 14 sessions in 4 weeks with 2 sets of 10 repetitions for each exercise. Group B received resistance exercises like isometric strengthening of quadricep and hamstring using ankle weights or stationary bicycle. With the baseline treatment with 12 sessions in 4 weeks with 2 sets of 10 repetitions. The outcome measures were assessed at the first day and at the last of 4th week and then analyzed. This is the consort diagram for my study. With the patient assessed for eligibility were 30, 2 excluded were not fulfilling the inclusion criteria, and then the 28 were randomly allocated into group A and group B with 14 each. 1 patient were dropped out from each group, and then the 13 each from group A and B were analyzed using SPSS version 25. These are the pie chart of my gender. Group A have 5 females and 8 male. Group B in group B there were 7 females and 6 males. This is the histogram for the age of group A and group B. This is the histogram of BMI for group A and group B. Normality, as you can see, to test normality, Shapiro-Wilk tests were conducted, and then the parametric tests were. This is the result of within group comparison of numeric pain rating scale. As you see, for both group A and group B, p-value is less than 0.05 and it is statistically significant. But group A shows more significance than group B. For Berg balance scale, both groups shows statistically significant values of 0.05 less than. For SF36, again, group A shows more statistically significant values than group B. Same for the WOMAC scale. In the previous study it shows that calisthenic exercises along with conventional knee osteoarthritis exercises producing reduction in numeric pain rating scale score from 7 to 5 and improve functional ability in patient with knee osteoarthritis after 4-week intervention. In my study, calisthenic exercises reduced numeric pain rating scale from 7.76 to 3.5 and improve functional ability in patient with knee osteoarthritis after 4 weeks. A study conducted in 2021 revealed that low-intensity exercises significantly reduce the pain and disability as compared to high-intensity exercises in knee osteoarthritis. The result of current study showed the calisthenic exercise significantly reduced pain score and function was also improved as compared to the resistance exercises. A study conducted in 2023 showed that calisthenic exercises produces significant reduction in numeric pain rating scale, WOMAC, and Berg balance scale. My study shows calisthenic exercises significantly reduce the numeric pain rating scale from 7.76 to 3.35, WOMAC score from 80.6 to 67.9, and Berg balance score from 29.38 to 42. The conclusion of my study is that both treatment technique, calisthenic exercises and resistance exercises produce a significant difference in patients with knee osteoarthritis. But calisthenic exercises were more significant in treating pain, function, balance and quality of life as compared to resistance exercises, as the mean difference of group A was far more greater than group B. Limitations of my study is that a control group to test the efficacy of calisthenic and resistance exercises was not included in the study. Psychological factors were not assessed in the current study that could affect the chronic pain of the patients. I would recommend that to perform research on the effect of calisthenic exercises combined with other exercise regimes like conventional therapy for osteoarthritis, proprioception training, as calisthenics show great effects on knee osteoarthritis. It is recommended to perform further research to see prolonged effect of intervention on knee osteoarthritis. For clinical purpose, calisthenics can be considered along with shortwave diathermy and other electrotherapy modalities. These are the references of my study. Jazakallah khair.
Now I will invite Hafiz Muhammad Amir Hanif to please come and present your work.
Assalamu alaikum. Good morning, ladies and gentlemen. I am Dr. Hafiz Muhammad Amir Hanif, orthopedic manual physical therapist. I am honored to stand before you today at this distinguished event organized by Rifa International University. Today I am here to present my research topic, which is effect of ergonomic consideration on musculoskeletal disorder and posture in software developers. First of all, we will discuss musculoskeletal disorder. Musculoskeletal disease are prevalent side effects of poor computer-related working circumstances. Musculoskeletal disorder include a wide range of inflammatory and degenerative conditions affecting the muscles, tendon, ligaments, joints, peripheral nerves, and spotting blood vessels. People who use computer keyboards for more than 15 hours per week participated in a randomized controlled study of 2 different workstations and postural interventions. The incidence of neck shoulder complaints and hand and arm symptoms in the interventions group was compared to the incidence in computer users who did not receive an interventions over a 6-month period. Ergonomic principles which have been shown to be more effective in the reduction of musculoskeletal problem and restoration of function in the participant, and to evaluate the whole body postural musculoskeletal disorder and risk associated with job tasks. Now we will move towards the literature review. In 2021, the risk assessment for the musculoskeletal disorder based on the characteristic of work posture, and the finding was rapid entire body assessment, that is RIBA method, had a lot of potential for the risk assessment in real time, and it can output all changes in work limb angles in the work process frame by frame and determine the overall risk level of the procedure. Another study in 2015, work-related musculoskeletal disorder of upper extremity with reference to working posture secretaries. And the finding was RULA as a tool for the assessment of upper limb of the body, and the outcome is shows a high prevalence of upper extremity and low back musculoskeletal disorder among secretaries. Material and methods. Study design was quasi-experimental study. Setting was software houses in Lahore. And the duration of the study was 6 months after the synopsis approval. Sampling technique, non-probability, consecutive sampling, study group. Postural correction exercise was given to all participants included in the study. Sample size calculated through raw software is 250. Sample selection through inclusion criteria and exclusion criteria. First of all, we will discuss inclusion criteria. Software engineers who have experience of more than 2 years in the same company. Software engineers with the age of less than 40 and both gender, male and female. Exclusion criteria, software engineers who had a past history of spine surgery or disease in spine like disc prolapse, discitis, arthritis, etc. Orthopedically, physically challenged, and pregnant female. The variable of the current study was body assessment, upper extremity assessment, and self-assessment. Now we will discuss interventions. Ergonomic principle. There are fundamental principles of ergonomics which are working in a neutral posture, proper posture maintenance is necessary. Working too long with C-curve can cause strain. Keeping the proper alignment of neck, hand, wrist are also necessary. Intervention. Reduce excessive motion, repetitive motion needs to be avoided. This can cause disorder and numbness in long run. Minimize fatigue and static load. Fatigue is common strenuous work. Having to hold things for longer periods is an example of static load. Fatigue can be reduced by the interval and the breaks between the work. Move, exercise and stretch. Move and stretch when you can. It's better to take interval between the works and stretch and move along. Stretching technique may differ and depends on the work one does. Maintain a comfortable environment. This is focused on the other component of working environment. It is concerned about lighting, space, cool air, and many more. Data collection procedure. Data was collected from software developer companies in Lahore, and questionnaire included demographic data and data collection tool. Software developer was guided by the basic ergonomic principles to maintain their posture at workstation, and data was collected at the start of study and 2 stages with 2-week intervals. These are the variables of the current study: age, height, and weight. This is the pie chart of BMI. There was statistically significant difference between pre and post value of RIBA and RULA questionnaire. Now we will move towards discussion. In 2020, evaluation ergonomic of desk-bounded work offices of a community health center and effects of ergonomic interventions on the health complaints of the worker. They used implementation survey ergonomic observation as a tool. And the outcome of the proportion of the participant with at least one area of musculoskeletal complaint decreased from 81.2% to 62.5%. While the proportion of the participant with an eye complaint decreased from 52.5% to 28.7%. According to the current study, we also use the ergonomic principle for software developers, which are also chair and table bounded workers. So the outcome was same and sound good because it decreased the musculoskeletal disorder in software developers after using the ergonomic principle. Conclusion. It is concluded that there is correlation between postural correction and musculoskeletal disorder, and applying ergonomic principle, there was positive improvement in musculoskeletal disorder. Limitation and recommendation. Limitation: not able to monitor posture for long time. Human error is possible, not monitored by cameras. Recommendation. Ergonomic principle must be used by software developers to minimize the occurrence of musculoskeletal disorder. Researchers used Rula and Riba questionnaire for postural assessment, and ergonomic principle should be studied in other population in our community. These are the references. Thank you so much.
Thank you, Dr. Hafiz Muhammad Amir Hanif, for your presentation. Our next presenter is Dr. Sufyan Nawaz, who will talk on the association of piriformis tightness with low back pain due to prolonged sitting among bankers. Please come on the stage and present your work.
Assalamu alaikum, hello and very good morning to our distinguished guest and our beautiful audience. Myself, Sufyan Nawaz. First of all, I would like to thank the whole team of Rifa International University for giving me such an opportunity and chance to present my research work. So here's the title of my research, The Association of Piriformis Tightness with Low Back Pain Due to Prolonged Sitting Among Bankers. First of all, I will start with the introduction. I will let you know the little bit anatomy and function of the piriformis muscle. As we all know that the piriformis is a flat muscle, which is the superficial muscle of the deep gluteal region, which is activated in all type of sitting posture, whether it is a high sitting or a cross sitting. Although its position and function changes in different style of position sitting. Sitting on a chair for a prolonged period of time put a pressure on piriformis muscle, and piriformis muscle become tight. And when the piriformis muscle is tight, its diameter increases. Due to its location, it creates pressure on sciatic nerve and creates sciatica-like symptom that is called piriformis syndrome. Low back pain is the most disabling condition worldwide, and the most important cause of low back pain is piriformis syndrome. So this study was conducted to identify the prevalence of piriformis tightness among bankers and to find out the length of job experience who suffered from piriformis tightness. Here, literature said that Ata Muhammad conducted a study in 2021, the prevalence of piriformis tightness among undergraduate medical students. Total 200 participants were recruited, and data was analyzed by a fair test. And the conclusion was that the piriformis muscle tightness was those who are engaged in prolonged sitting. In Malika Model 2018 conducted a study on prevalence of piriformis tightness in healthy sedentary individual. Total 200 participants were recruited, and tightness was checked by a seated piriformis stress test. The conclusion said that the sedentary population are more prone to accept piriformis tightness. Here are the method and material. It was a cross-sectional study design, and the data was collected from the major private bank of Sialkot and Lahore, and convenient sampling technique were used, and sample size was 200 participants, which were calculated by API tool. Here is the inclusion and exclusion criteria. The participants with the age of 24 to 60 years were recruited, and all those participants who have 8 to 10 hours of job. And exclusion criteria, all the participants who have any serious disease of spine, pelvis, femur, and sacroiliac joint were excluded. Here's the diagnostic set. As you can see, the sensitivity and specificity of the test is mentioned here. Seated piriformis stress test and goniometer, which are used to measure the external rotation of the hip. Here's the diagnostic test. This is a seated piriformis stress test. As you can see in first picture, which is the starting position of the test, patient is in sitting position and grasping the edge of the table to stabilize the trunk and pelvis. Ask the patient hip is flexed approximately 90 degree and the knee is locked. Therapist sitting in front and beside the testing leg and internally rotating and adduct the leg to pressure to stretch the piriformis muscle. To consider the test is positive, the patient complain pain and discomfort in buttock region. So here is the data analysis tool. Pain was analyzed by NPRS, numerical pain rating scale. Here the reliability and validity is also mentioned here. This is a flow chart of this research. Total 240 participants were recruited and informed consent was taken and evaluated as per inclusion and exclusion criteria. 40 participants were excluded due to 17 were refused, 8 has spinal deformity, and 9 were recent surgeries, and 7 were excluded due to sacroiliac joint dysfunction. This table shows that socio-demographic information of the participant. As you can see, all the demographics and their total value and mean and standard deviation values are mentioned there. This is the frequency measurement. All those participants who are tested positive piriformis test and was the 73.5% and 26.5% was tested negative. And p-value was 0.001, which shows that the piriformis test was highly significant. This bar chart shows that the association between diagnostic test and range of motion, which is the external rotation. First bar shows that the 46 participants were those who have hypomobility, but their test was positive. Second bar shows that 50 participants were those who have hypermobility and their test was positive. Third bar shows that 51 participants were those who have test is positive and normal range of motion. This bar chart shows that the prolonged sitting affected low back pain or radiating pain, whether the piriformis muscle tightness put pressure on sciatic nerve and patient complain the piriformis syndrome-like symptoms. So 58 participants only complain of mild pain. Discussion. In 2018, Malika model conducted a study and checked the prevalence of piriformis tightness in healthy sedentary individuals. The prevalence was 79.5%. In current study, the prevalence was 73.5% and mild association of piriformis tightness with low back pain. In 2020, Samrez Mughal conducted a study on the male population of bankers, and the prevalence of piriformis tightness was 65.4%. In current study, the prevalence of piriformis tightness was high. This may be due to unsupported chair and poor ergonomics and poor sitting posture. Conclusion, this study concluded that the incidence of piriformis tightness among bankers was high due to prolonged hours of sitting. Further, only mild association of piriformis tightness with low back pain seen. Recommendation, further researches should be conducted to evaluate the other factors associated with piriformis tightness, for example, sciatica. Further studies advocate to develop awareness and preventive strategies to overcome the piriformis tightness. Awareness and education about posture in sitting position and importance to maintain the active lifestyle should be conducted through seminar to enhance overall work performance. These are the references. Thank you and Jazakallah khair.
Thank you so much, Dr. Sufyan. As it was the last presentation of today's session, now I would request the chair and co-chair to please conclude the session.
Assalamu alaikum. Thank you, Priya. So we have a short of time, so no question answer from the researchers, but there is some journal, our assessment on these researches. The first thing is, when you going to compare the school of thoughts, you first know the basic concept of a school of thought. So please don't go without any basic knowledge to compare these school of thoughts in your perception. The second thing, we observe that your age bracket is very large. So we know that in Pakistan populations, we have a different etiology and different behavior of the degenerative changes. So your age bracket should be very compromised. The third thing is that we all are going to do RCTs. Yes, RCT is good, so make it simple and go for your need-based research. Another thing is that you have a specific, very low number of sample size, and you have in regular, when you're going for the intervention, you have faced the dropouts patient. So you have to mention each and every patient. So don't go for that you mention that there's only dropouts and same numbers in both groups. And when you compare the two different treatment regime, you must focus on what is a conventional treatment protocol. You don't minimize the treatment procedure of that particular disease. You have a particular conventional treatment protocol. Don't bias yourself. Don't put patient into a risk of low treatment. In the literature, when we're going to cross a different type of some exercise or some techniques, we are not so much in that position. So we concluded that exercise is better than, or that exercise or that technique is better than that technique. So give your opinion, and especially in your conclusion, that according to my study research, I found that according to my data and my result, we see that this result is happen because we cannot mention here that this technique is better than the other technique. There's a big name in our manual therapy and musculoskeletal school of thoughts. I just mentioned some weakness and observation, but being a novice researcher and my students, you did a great job at the end. You're doing a good job, but please, when in future, you must think about some of my observation. Thank you so much.
First of all, thank you very much for those presentations. I think as a group it was very impressive and I enjoyed them very much. I'm going to make a couple comments. My co-chair colleague is much more of an academician than I am. I'm more of a clinician, and so I'm always looking for the clinical punchline, or how can this direct care? And so I'm going to just make a few comments on that. The first presenter, and forgive me if I mispronounce your name, but Anand, this was the scapula stabilization versus thoracic extension. And this goes for many of these treatments. I feel like there needs to be an attempt at a control. Many of you used sort of a common treatment as a control, but when you have different types of therapeutic interactions and interventions, it's always going to affect your results. It comes into it's more powerful when you're adding manual therapy versus exercise alone. So that's something to think about. The Mulligan mobilization with clamshell for SI dysfunction. My one comment there is, you know, a clamshell for a different individual is completely different based on the dosage. If you think about a big athletic muscular person doing clamshells versus somebody who's very thin, small muscles, the percent of a 1 repetition max is completely different on different people. And so if you're going to make a statement about a clamshell making an effect, you should know that you're doing strengthening or coordination or vascularity or all the different things you could dose exercise for. And that came up with some of the exercise concepts that were used here. The fourth presenter, Tarim, this was the distal radius fracture. Interesting findings for sure, but again, if you're adding manual therapy, you need to have a group that has some sort of sham manual therapy. So there's some sort of therapeutic touch happening, that therapeutic alliance is being fortified with manual therapy, and so that's something to think about. And then I was wondering, and I don't need an answer, but the selection of concentric exercise specifically to gain range of motion, it was a question for me about why that was chosen specifically, and if that meant literally concentric exercise and elimination of eccentric with that exercise. So that left me with some questions. Next, Sana. This was an ambitious question to evaluate core muscle activation on chronic low back pain. I think a lot of the problems with physical therapy research is there's not enough subgrouping. And so if you take 100 patients who come in and you treat half of them one way and half of them another way, your outcomes they're just going to be okay. And so that's where evaluating and determining which patients need core strengthening and which don't is going to completely change your outcomes. So that's just a clinical comment. And the same comment for the Roccabato versus Krauss for temporomandibular disorder. You know, the question should not be which technique is more effective, it's which patient fits the technique best. And that's going to be determined by your evaluation, and you're going to improve your outcomes that way. It's not a matter of deciding which one is most effective. The study with knee osteoarthritis, I think was great because it's such a common thing. But again, what is the dosage for resistance exercise? What is the definition of that compared to calisthenic? And to me, calisthenic is a very generic term. It might be different in Pakistan, but I would need some more information about what is that? Is that a stationary bicycle? Is it just active motion? What is calisthenics versus resistance training? And when you use the word resistance training, it should be defined. Is it what % of a resistance maximum? And then also from the clinical side of things, starting with low resistance until the irritation and pain is better, like happened in the study, and then moving to strengthening is really what we're going to do in the clinic. And so again, it's not, is it this one or this one? It's when in the progression of care you add these different kinds of exercises when you think about it from a clinical standpoint. The ergonomic intervention study I thought was great, and I think one of the recommendations should be, can the benefit be correlated to a savings in economics in terms of the cost for medical care, because that's going to motivate employers to implement ergonomics, and so that would be a great recommendation for further study. And then finally, I thought the piriformis tightness, I mean, the outcome was, I thought, great, that 73% of the bankers had a positive test, but just a mild association of low back pain. And to me, that just is more evidence that you have to evaluate the patient. You can't rely on a single test to drive your treatment. And so finding a tight piriformis is just simply a finding. It's not a diagnosis. And I think this study really emphasized that. Thank you very much for your time. These were really brilliant researches. Thanks.
Thank you so much, our respected chair and co-chair, for your worthy remarks and concluding remarks. Now we will move towards this certificate distribution ceremony. So I will request the chair, Dr. Alec Kay, and co-chair, Dr. Abdul Ghafoor, to please come on the stage and for the certificate distribution among the participants. Sir, please, once again, I am calling you. I will take the name of the participants one by one, and then you come and receive your certificate. Anam Abbas, thank you. Rahat Afzal, beta us side से yes. Ahmed Jamal, Tahreem Raza, Sana Gohar, Ifra Zulkarnain, Etemadur Rahman, Hafiz Muhammad Amir Hanif, Sufyan Nawaz. Now I will request all the participants to please come on the stage for a group photo with the chair and co-chair. All participants of oral presentation, please come on the stage. सर को बीच में कर लेते हैं ये पिक्चर सर को लेने में हाँ बॉयज इस साइड पर आ सकते थोड़े से आप तो फेरी पूरे आएंगे थोड़े से आगे आगे Thank you all the participants for being patient. Now I request you all to please move to the Grand Ballroom A for the Rehab and Allied Health Expo. We have 70 sponsors over there. Please visit them. Thank you.
कुछ बोलते हुए कि ले लो
Assalamu alaikum everyone. Now it's a time to visit the expo, and the next plenary will start inshallah at 11 a.m. So all the international keynote speaker national keynote speaker and conference delegates are requested to visit the expo with the adjacent hall GBRB.